In this next section, we're going to talk about metabolic acidosis. This is a decrease in pH as a result of a decrease in bicarbonate. So you're seeing low pHs with low bicarbonates. And we talked about this in the last section. There's three major etiologies. One, you have excesses in exogenous, or things that you ingest or take in, acids, or organic acids, such as those that are naturally found in your body. The other thing that can occur is you have a loss in bicarbonate. Also, you can have what's called dilutional, or having non-alkali containing IV fluids. An example of this would be normal saline is considered a dilutional cause of metabolic acidosis. As mentioned before, acidoses are one thing we have to do when we have a metabolic acidosis is calculate the anion gap, because there really is two major types. One, you have an anion gap versus a non-anion gap. Metabolic acidosis. So you look at this serum anion gap. Again, you've seen the calculation before. It's normal to be around 9 with a range between 3 to 11. However, if it's greater than 17, that is usually our cutoff to say that it's an anion gap. So if it's greater than 17 versus non-anion gap will be less than 17. Again, this helps us differentiate types of etiologies, with anion gap meaning that you have bicarbonate being consumed by exogenous or endogenous acids. So we'll talk about some of those examples in here in just a minute. Versus non-anion gap, also known as hyperchloremic, you're having the bicarbonate being replaced by chloride in the system. So this is due to usually excessive renal or GI losses, or due to dilutional non-alkali solutions being administered rapidly, such as normal saline. Whenever we talk about anion gap metabolic acidosis, one easy mnemonic to remember is mud piles. Another mnemonic is gold marks. Both of these show some of the major causes of anion gap metabolic acidosis. There's only a certain amount of things that cause excessive acid in the system that leads to low bicarbonate. And they can include things like methanol and other alcohols like propylene glycol and ethylene glycol and alcohol-induced ketoacidosis. You also have your endogenous acids such as diabetic ketoacidosis and lactic acid. You can also use this mnemonic gold marks, which is a little bit shorter. That includes glycol, so propylene or ethylene glycol, oxaproline or excessive Tylenol, L-lactate and D-lactate. We'll talk about the difference between those two just momentarily. And then methanol, aspirin, renal failure, or ketoacidosis. What I want you guys to really focus on are these 5 different ways to differentiate between different types. So, first thing you can do to help differentiate between types of metabolic acidosis or anion gap metabolic acidosis is calculate an osmolar gap. If you have an elevated osmolar gap, which you guys learned how to calculate in the last section, you can consider it being a methanol, ethylene glycol, or propylene glycol cause. Versus, if you see that you have a high serum lactate, you can consider lactic acidosis. If you have a high beta-hydroxybutyrate, it's usually diabetic ketoacidosis or a type of ketoacidosis. For our purposes, DKA is amongst the most common. Having low GFR means that you probably have a renal failure caused due to uremia. And then finally, having a high salicylic level would tell you that you have aspirin toxicity. Each of these have their own treatment courses. One that I really want to focus in on today is serum lactate being elevated or lactic acidosis, because it is one of the most common causes of acidosis and anion gap metabolic acidosis. So this is the most common cause, and it usually occurs whenever lactate is greater than 4 millimoles. You have two different types, D-lactate, which is less common in humans, and it's usually due to short gut syndrome, inflammatory bowel disease, and malabsorption. And this is because these D-lactate is largely regulated by the microbiome in the gut. versus L-lactate, which is much more common, with two different types. One, tissue hypoxia. This is whenever you have sepsis or hypovolemia, causing your tissues not to be perfused with enough oxygen and leading to excessive lactic acid. Or you can have type P, which is non-tissue hypoxemia, which is usually due to drugs, such as certain HIV medications and commonly, or more commonly, maybe metformin. So just remember, type A, tissue hypoxia, type B, non-tissue. L-lactate is much more common than D-lactate, which is mostly associated with microorganisms. When we treat lactic acidosis, the first thing we want to do is make sure that we get plenty of fluid resuscitation. You may need to use vasopressors or ionotropes or oxygen supplementation if you have hypoxemia. If the reason why you have severe tissue hypoxia is because you have an anemia, because your body is not providing enough oxygen via its hemoglobin, then you may need to do a blood transfusion, and sometimes you may have to do a surgery to restore circulation or remove damaged tissue. Overall, you do want to make sure that you treat the underlying cause and provide adequate hydration. Now, there are some bicarbonate or basic substances that you can give. However, this is only really reserved for severe cases, and they have not been shown to have any clinical benefit. As I highlighted here, the calculation is just an FYI, but our overall goal is to just increase the pH just enough to be at 7.1 to 7.2, or have a bicarbonate between 8 to 10. Unless you have a bicarbonate outside that spectrum, you do not need to give this treatment. So, looking back at our flowchart, if your pH is low, with the primary problem being metabolic acidosis because you have a low bicarbonate, the first thing you want to do is calculate your anion gap. If your anion gap is less than 17, it's a non-anion gap metabolic acidosis, and that will lead us to the next section. If it is greater than 17, it's an anion gap. So either think mud piles or gold marks being the major causes. If you see that the osmolar gap is greater than 15, it's usually an alcohol or toxin-related disease, with it being methanol, ethylene glycol, or propylene glycol being the primary cause. If your lactate is greater than 4, you consider lactic acidosis, and then you need to make sure you remove the underlying cause, provide adequate hydration, and in some cases, vasopressors or inotropes. If the primary problem is beta-hydroxybutyrate of greater than 1, you can consider diabetic ketoacidosis or a type of ketoacidosis as a primary problem, and thus you will treat that accordingly. If the GFR is less than 30, you should consider uremia due to renal failure. And then finally, if you have an elevated salicylate level, it's salicylate toxicity. All of these values, other than the osmolar gap, will be given to you on an exam.